Thank you, Christian, and thank you, Dominic, for this kind invitation. It's a double pleasure for me to talk about multiple sclerosis, but in particular to talk about, to give a presentation in St. Louis Hospital. I had the privilege to be a pupil of a young Luqman many years ago. My first experience in transplantation was in Trèfle-Trois. And so I'm particularly pleased to give a presentation many years ago. I still feel to be a pupil of this hospital. So my task today is to give a brief overview about the 20 years experience in multiple sclerosis. And therefore, I started from the beginning and found this slide, which was presented at the annual meeting in Istanbul 2002, so almost 20 years ago. And just to see where we were, just a few years after the creation of Autoimmune Disease Working Party by Alois Graftful at the time, Alberto Marmon. And you see that at that time, we had something like a bit less than around 500 procedures, and we had 150 patients transplanted for multiple sclerosis. The update has been already shown by the other colleagues in the previous presentation, so I will not waste time for that, just to say that we are now more than 3,000 procedures reported to the EBMT registry. It's quite important to see this data, that the median follow-up is 4 years. That was a major problem when, at the very beginning, when we analyze the data from the registry, and usually specialists, neurologists or rheumatologists said, well, 1 year is too small. It's good for a leukemia, but not for a scleroderma or for multiple sclerosis. Now we have a patient reported and followed for many years, so it's quite a relevant issue. This slide was already shown, but I briefly want to outline a couple of points. The increase of the activity in the last few years. In 2010, we have the introduction in the clinical practice of a big competitor, which was natalizumab, and you see a fast drop of the activity, but then the activity increased despite the introduction here of alemtuzumab and now here of ocrelizumab. So despite the introduction of a very effective drug with apart from alemtuzumab with a good safety profile, the transplant is increased and is now stable, almost 200 procedures per year. So that transplant works. It was evident since the very beginning. It is a pivotal paper we published many years ago, 15 years ago, showing that the conditioning regimen, but before the conditioning regimen, also the mobilization regimen, 4 grams per square meter of cyclophosphamide were able to decrease remarkably the number of active lesions at MRI, which dropped to 0 and then persisted. So this data has been then confirmed in the following years. Also, this slide was already presented, but I want to point out an important issue here, which is the limit of any retrospective analysis. These are supposed to be relapsing remitting patients, and when a relapsing remitting patient is transplanted and develop a progression 1 or 2 years after the transplant without relapses, without new lesions. So that means that that patient was not a relapsing remitting patient. That patient was already in the transition phase toward the progressive phase. At that point, any conditioning regimen, any type of treatment is not able, roughly, to stop the progression. So we have to play our role before. And this is the disability before the transplant in relapsing remitting patient, and you see that the number of patients tend to decrease and remain stable. So this is the window in which we can actually provide a clinical option for these patients. Despite the big heterogeneity of the patient, of the case series, we can see that the data can be, let's say, repeated. You have number of papers. This is the Italian series, 70 patients, all treated with the same conditioning regimen. This is the Swedish activity, mostly with beam at the time. This is the Russian. And you see that in most of cases, you can have a plateau after the second year with about 70 to 80% of patients who do not progress in the disability, and the vast majority of these patients do not receive any maintenance treatment. This is another pivotal study, a small number of patients where we compare the transplant versus mitoxantrone, showing that the transplant was much more effective than mitoxantrone in the 4 years of the follow-up in inhibiting the number of new lesions at MRI, so the most sensitive parameters that we have. And when we tried this Maria Pia Sormani analysis to look at the literature and to assess the possibility or the capability of active treatment, in particular this one, there are more modern and effective treatment to induce a non-evidence of disease activity, therefore, which means no new lesions, no relapses, no progression of disability, and you compare the data from published study with this drug and the transplant, you can deduce that the transplant, according to published data, provide a higher probability to maintain this NIDA status. And I have to emphasize that these patients were transplanted in a much more advanced phase of the disease as compared to all the most recent trials. But the disability is not the only parameters that we should consider when assessing the efficacy of a treatment, but also the overall quality of life in this type of chronic patients is quite important. This is our study many years ago. We showed that all the parameters were reported a significant improvement of quality of life. This paper by Richard Burt in the prospective trial. This is another study from the Canadian colleagues showing that fatigue, which is one of the dominating symptoms in MS, which affects the quality of life of this patient, improve after the transplantation. A few words, let's say, on the conditioning regimen, which is still an unanswered question. You can see here from this, in this cartoon, you can report the intensity of the conditioning regimen, and we go from cyclophosphamide to beam to the Canadian protocol. Is extremely aggressive regimen, including busulfan, CD34 selection, ATG, high-dose cyclophosphamide, and the mobilization. So the big question is, do we have an impact of the conditioning regimen either in the safety, which is obvious, but also in the efficacy? Can we actually use a low-intensity conditioning regimen and have exactly the same results, so better outcome and no toxicity or lower toxicity? We try to make a meta-analysis of a number of papers published, and if we look, if you consider the progression, progression in 2 years from the transplant, the only significant parameters as expected is the phase of the disease. A relapsing remitting patient are doing better than a progressive patient as expected. But in terms of transplant-related mortality, you have 3 parameters. One is the year of the transplant. In all the analysis, the mortality after the transplant decreased, especially after the year 2000, 2005. And the baseline, so the disability at the moment of the transplant, the patient in a better shape are doing better. And once again, the proportion of patients in the relapsing remitting phase as compared to progressive. But if we look at the intensity of the regimen, we didn't find a difference, neither in terms of progression, so let's say efficacy, or transplant-related mortality. So I like to quote two extreme examples. One is the Canadian result. The Canadian study, as I said before, is probably the most aggressive regimen which has been reported in multiple sclerosis. But if you look at the results, in terms of relapses or new lesions at MRI, in red triangles are the relapses or positive active lesions at MRI. To my knowledge, there are no studies which show the complete eradication of any inflammatory activity, both clinical or MRI, than in this study. Despite of it, there is some time to improvement, and some of these patients progress anyway because they were already in the progressive phase. So a high-intense conditioning regimen cannot prevent progression of disability if you already entered into the progressive phase of the disease. We did a short study with a low-intensity regimen, cyclophosphamide and full dosage of ATG, and we look at the MRI with a triple dose of gadolinium, which is a very sensitive parameter to look at the MRI activity. So you can detect 70% more gadolinium-enhancing lesions as compared to the standard dose of gadolinium. And we did this analysis in this monthly, the 6 months after the transplant. We found that most of these patients, despite that they had a clinical remission, still had some activity. And when we compare with a matched patient treated with BEAM in a previous study, we found that there's a difference. So probably in terms of a capability to eradicate the flare in the central nervous system, the dose intensity, or let's say the intensity of conditioning regimen, can provide some differences. These are our data in Florence. We have always used BEAM. Now we have transplanted last week our 97 patients. This is the early adverse event. We don't have a casualty in our series. The viral reactivation is very common, but once again, we confirm the results. So these are 15 years, 80 years here, and you can see that the relapsing remitting patient show a stable disease, 70% of 10 years from the transplant, and none of these patients has received chemotherapy or let's say any treatment after the transplant. So once again, the choice of conditioning regimen, this is the previous speaker has already shown the switch from the BEAM, which was the most popular regimen in Europe, versus the increasing use of cyclophosphamide following the pivotal works of Richard. But you can see, first of all, that we have some difference in terms of population. At the beginning, we treated patients more often in the progressive phase. And now, most of patients transplanted with cyclophosphamide have a lower disability and are mostly, or more frequently, in relapsing remitting phase. So it's quite difficult to compare this group of patients. There are differences also in terms of the age of diagnosis, age of transplant, disability at the moment of transplant, and number of relapses before. Well, the number of relapses was similar in the two groups. So once again, that two groups were quite different to compare, and we have to stratify patients according to a number of variables, which is usually hard to find in a retrospective analysis. What I can say that in terms of engraftment, the two regimens are exactly the same. As you can see here, the Kaplan-Meier showing the engraftment. The overall and transplant-related mortality was low, so 1.4 in this series of about 900 patients reported to the registry, slightly higher in BEAM, so about 2% versus 1%. The problem was, the good thing is extremely low. The bad thing is extremely difficult to compare from a statistical point of view the incidence of that. We went on the analysis together with Manuela Badoglio. Yesterday we tried to squeeze the data, the neurological data. So far we don't find a significant difference between the regimen in terms of relapse prevention. Once again, the relapse incidence is so low that you probably need many patients and possibly in a prospective way to find the difference, if any. So we conclude in this abstract that we submitted to the EBMT, which is now have the new that is accepted as no representation. It is a comparative trial is likely needed if you want to provide a reliable information on this question. But in the meanwhile, and these are my last slides, we decided together with Dominic to launch a trial which is now probably a bit obsolete, because I didn't mention that for the sake of time, but there is a number of prospective comparative trials which are going to be launched in Europe. One is in Germany, one in UK, STAR MS. One is just started in the Nordic countries. In Italy, we got the grant and we are now preparing the trial. So usually it's a transplant, which is usually cyclophosphamide, except from in Italy we will use still BEAM, versus the best available treatment or one treatment which is usually ocrelizumab or alemtuzumab. But despite of it, given that many patients will not be enrolled in that, and having in mind the last consideration about the need for a comparative trial, also to have a good, reliable data about the choice of conditioning regimen, we are launching as EBMT this prospective observational trial. These are the co-investigator, including Dominic Fage, study coordinator is Manuela Badoglio, and the primary objective is to gain further evidence of clinical efficacy, secondary objective, safety, tolerability. The primary endpoint is the time to failure to maintain non-evidence of disease activity, and then a number of conventional secondary endpoints, including, last but not least, the improvement of disability. Many patients improve after the trial, and the improvement is sustained. So the inclusion criteria will be all patients with a diagnosis carried out according to the last revision of McDonald's criteria, that means including MRI, and the availability of detailed clinical history about MS. We cannot compare patient with a low activity and a high activity. So we need to know how many relapses of those patients had in the previous 2 years and so on. So we think to include 50 patients in a couple of years. Of course, it is an observational study, so we cannot dictate the monitoring of the patient. But according to the clinical practice, one patient with such a severe MS form to deserve a transplantation need to have at least an yearly MRI after the transplant together with a neurological examination. So the study is going to be launched very soon, and we hope to have also some French colleagues participating in that. So my conclusions is, as already said, with the transplant we can achieve a long-term stability or often an improvement in a high proportion of patients with an overall acceptable safety profile. We know already that the long-term efficacy is better in younger patients than relapsing remitting forms. the data from publishing literature in terms of progression-free survival are reproducible. The optimal intensity of the procedure, including a conditioning regimen, is still to be defined. We have discussed many times also with Richard, and we think that probably we don't have the best conditioning regimen, but probably we can tailor the approach. In a catastrophic patient, young women with 14 new lesions enhancing gadolinium, poorly responding to high-dose steroid, probably you need to use something stronger, such as the beam. In a patient with still active disease, with a long-term diagnosis, with some new lesions at MRI, not responding to conventional treatment, probably cyclophosphamide is enough. It's the best equipoise between safety and efficacy. So we have to have some information in this prospective trial. Last but not least, the full integration between the doctors and the nurse is crucial, and of course also the neurologist and the hematologist is crucial for a positive outcome. A number of people who has contributed to this data. I'd like to thank here Dominic, Manuela, Miriam Labopin, and a number of other specialists around the world. So with the dome of the cathedral of my town, thank you for your attention, and I'll be delighted to have questions.